Welcome everyone to Volunteering for Seniors virtual webinars for senior citizens and their caregivers. Good morning. This is Pratima Penumarti, CEO, founder, and president of Volunteering for Seniors. Our vision is to build a society where every senior is empowered to live life to their fullest potential. We are guided by our core values of compassion, service, volunteerism, good stewardship, and diversity. Since the year 2021, we have been conducting VFS virtual webinars, talk shows, conferences for senior citizens, and keynote presentations, even general sessions that focuses on supporting health and self-care of seniors and their caregivers, even for older adults and individuals who are with or without dementia across USA. People with pre-diabetes, as per research, they have up to 50% chance of developing diabetes over the next 5 to 10 years. As the general population continues to age, the number of adults 65 years or older, they are affected by diabetes, and who are affected by diabetes is also increasing. An estimated, all this according to the research, an estimated 33% of adults aged 65 or older, they have diabetes. So this population is more at risk of developing diabetes-related complications like most of us know, hypoglycemia, low blood sugar, kidney failure, and heart disease than younger people living with diabetes. So today, with respect to this, of course, with diabetes awareness, we'll be learning more about this disease and how it affects us. So please join us for this wonderful informative webinar with Dr. Chandra Lingisetty, who's an MD, MBA, MHCM, and who is an experienced healthcare leader with extensive training and experience in healthcare. He served as a provider, leader, executive, and innovator at various healthcare systems, and is presently working as a chief medical officer at eternalHealth, a Medicare Advantage health insurance company. Welcome, Dr. Chandra.
Pratima and the team here, thank you so much for the opportunity. And I feel passionate to spend my time today with this group here because VFS does what they say, and VFS is doing what exactly that is supposed to be done by every single human being that walks on the earth. I feel privileged as the Chief Medical Officer of eternalHealth. I'm thankful to our company for nurturing the activities we're doing and also supporting us through the collaboratives and community partnerships such as VFS. So without further ado, I really want to probably start discussing the important topic of the day today, pre-diabetes and diabetes with you all. So, if I run through these slides quickly, there'll be a lot of time for you guys to answer, ask me questions and I can answer. So absolutely thrilled to be here. And again, I can't think of any other better way of spending my Saturday morning than doing this very important session with you today.
Thank you, Dr. Chandra. I think before we start the presentation, I just want to tell the participants what they can expect in today's presentation, which will be slightly more than what our objectives are. It'll be basically Dr. Chandra will explain to us as to how to talk to their physicians during their appointments and what questions one can even ask the doctors to manage their healthcare, and also different strategies for responding to questions when asked by doctor. So thanks, Dr. Chandra, and we'll be excited here to start to see your presentation.
Wonderful, thank you. That really sounds like a good plan to me. Let's just jump into this right away. And I am assuming that you're able to see the presentation. Yep. Wonderful. All right, that's a little bit about me. Again, I am a physician, and I will be a physician forever, no matter what kind of other roles I pick up during my journey. And again, happy to be here. Again, thanks to our founder and CEO, and the power behind this is Pooja Aika, who is the founder and chairman of the eternalHealth, which is a Medicare Advantage health insurance company based in Massachusetts in US. So agenda today, quickly, let's talk about pre-diabetes and diabetes. Pre-diabetes Again, as the name sounds, it is something that is before diabetes hits us. We'll talk about it for probably 20 to 30% of the time, but the rest of the time we probably focus on diabetes and things we need to do. So for pre-diabetes, which sometimes confusing, people may say, oh, I was told that I was early diabetic, I was told that I am a pre-diabetic and whatnot. So different nomenclatures exist in the world today so as to identify a condition that comes before diabetes. So what is prediabetes? What are the symptoms and how do we diagnose prediabetes? And what are the risks associated with the prediabetes? And how do you manage it? And then jumping into diabetes, we probably will talk about briefly diabetes and symptoms and complications and how do we manage diabetes effectively. Starting with prediabetes, as you all know, prediabetes is a condition where the blood sugar level is not high enough to be called as diabetic, but it's not normal either. So that's the intermediate condition between normal blood sugars and type 2 diabetes, high blood sugar level. So that intermediate phase is called prediabetes. So again, we have a normal blood sugar here, and we have a diabetes range, high blood sugars up there, and the orange or yellow, whatever you want to call that, light in there, is the pre-diabetes condition. Why do we need to learn about pre-diabetes? To Pratima's point, we do have definitely about 33 plus percentage of diabetics among seniors. That's absolutely an accurate number. In addition to that, are we missing anybody, in the senior population? Yeah, the pre-diabetics. So the U.S. adults across 18 years to the other extreme of the life, 38% is the prevalence of pre-diabetes among all the U.S. adults. So that comes up to close to 100 million adults having a pre-diabetes, just a pre-diabetes, right? And then we have an additional 33% of diabetics as well in 65 or mature population. So that comes up to 1 in 3 American adults have a pre-diabetes. So if you put these two numbers together, pre-diabetes plus diabetes, I don't want to scare you, but those numbers, whatever Pratima mentioned, are absolutely spot on. You have a pre-diabetes of 38% and a diabetes of anywhere close to 20 to 33. You're talking about 50 to 60% of US adults have something to do with high blood sugar, whether they're pre-diabetic or diabetic, but they have something to do with high blood sugar. It is scary, right? If, say, for example, in this room, there are 20 of us, 10 of them have something to do with diabetes. Either they're pre-diabetic or diabetic. So something or other are going to hit them for sure if that is not prevented on time. So that's exactly the reason why we are sitting here today trying to learn. Again, as you might have rightly thought, pre-diabetes does not give symptoms in most of the people. So 9 out of 10 pre-diabetics do not have symptoms. They don't know it. So a little story. So I get a call at 11 p.m. from one of my very close friends that their relative in India is, acutely admitted to the hospital with what is sounding like a coma. And then I pick up a phone and I call them. Yeah, so that is a high blood sugar, almost push them into comatose situation with high blood sugar. And then they never knew that they had, pre-diabetes or diabetes affecting them. So that's the power of pre-diabetes. That's what it can do to us. So without even us knowing about pre-diabetes, it can hit us. It can just stay with us and live with us for a long time, and then suddenly one day manifest as a diabetic with uncontrolled blood sugars, ending up in the hospital. So that's why most of the pre-diabetics do not have any symptoms. Diabetics have symptoms, but pre-diabetics, most of them do not have symptoms. That's why it is important that we recognize the important that we recognize the impact of pre-diabetes. So a lot is talked about diabetes in the world so far. A lot is talked about it. People know what are the symptoms of diabetes and how to treat them, medication versus insulin and doing all that. So that's why when Pratima and her associates at VFS asked me to talk about diabetes, I requested them politely, may I have a chance to talk about pre-diabetes as well? And graciously, they have agreed to it. And then I'm here presenting half of my time on pre-diabetes because it is important that we recognize the pre-diabetes, because as the name sounds, if we do nothing about pre-diabetes, it is going to push you into being a diabetic, right? So I cannot emphasize that enough this morning. So how do we diagnose it? Simple. Fasting blood glucose, you check the fasting blood plasma glucose. Um, if that is a level above the reference range, you call as prediabetes. Simple. And there is one more test called HbA1c. I want all of us here to hold on to that thought there. Just remember that magic word, hemoglobin A1c, HbA1c test. So there is second test they use to diagnose prediabetes. And of course, glucose tolerance test, as some of you may recall, that used to be a previous method of diagnostics for the diabetes. We don't really use that often nowadays, but definitely those two, fasting blood glucose and hemoglobin A1c, are the tests. So let's take a look at what is normal blood sugar. Normal fasting blood sugar has to be 99 milligrams per deciliter or below. Okay, 99 or below. And let's just talk about fasting blood glucose or fasting blood sugar or HbA1c. Let's not talk too much about glucose tolerance test because that's not something that is really used, widely. And the normal HbA1c has to be below 5.7. And pre-diabetes, fasting blood glucose 100 to 125. That is the number, okay? That is pre-diabetes. And hemoglobin A1c 5.7 to 6.4. That is the number, right? Obviously, anything more than that is diabetes. 6.5 or above is diabetes, HbA1c. And blood glucose of 126 milligrams per deciliter or more is already a diabetes on the fasting blood glucose levels. I want us to memorize this slide, just to memorize it for a second. Question to you. So 5.7 HbA1c, is it normal or pre-diabetes? And all of you are smart. So the answer is pre-diabetes, right? I know you answered that correctly. So next question. A fasting plasma glucose or a fasting blood glucose of 100, is it normal or pre-diabetes? Yeah, I heard someone saying diabetes.
Diabetes.
Yes, that's right. This is pre-diabetes. Okay. 3 numbers for fasting blood glucose is bad news. All right. I want everybody to underline that word. 3 numbers for the fasting blood glucose is a bad news. It is pre-diabetes. Right. Now, who is at risk of pre-diabetes? Let's take a look at it. So people who may not have an opportunity to do enough physical activity are at risk of pre-diabetes. People who might have had diabetes during pregnancy, we call that gestational diabetes, risk of prediabetes. People with a close relative with diabetes, like mother, father, siblings, first degree relatives, aunts and uncles with diabetes at risk. People who have a habit of consuming tobacco, smoking, risk of prediabetes, and also people with overweight, or in other words called obesity, especially if the weight is around the belly area, truncal obesity, are at high risk of having prediabetes. So this is really a good, sheet. I want us to spend a minute or two on this. I will circulate a PDF of this to the group so you guys can go back and work on it at home. So simply, if you have a pen and paper, or maybe if you have a simple cell phone or a computer, just write your numbers. Just put it down as I walk you through for a minute or two. So the test is obviously American Diabetes Association and CDC is the think tank behind this particular grid. I want you guys to really carefully go through this. Diabetics don't have to do anything with it, because if somebody is already diabetic, this test is for the pre-diabetes, so is not relevant. People who are not diagnosed with diabetes and people don't know that they are pre-diabetic, whoever who is not diabetic here in this group today should do this test right now. So by the end of in the next 30 seconds or 40 seconds, you will know if you're a pre-diabetic or not. Okay, you ready with the first question? How old are you? If you are younger than 40, give yourself 0 points. If you're 40 to 49, give yourself 1 point. 50 to 59, give yourself 2 points. If you're 60 years or older, give yourself 3 points. Okay, you got that? So first question, younger than 40, 0, 40 to 49, 1, 50 to 59, 2, 60 years or older, 3. Just do nothing, just write those points on wherever. Even if you're sitting in a beach, write those points on the sand, please. Next question, are you a man or woman? If you're a man, give yourself 1 point. You think you're winning, but you're not. If you're a man and you are more than 60, you already got 4 points. I'll tell you why. So if you're a man, give you 1 point. If you're a woman, give 0. You're safe there. Question number 3. If you're a woman, have you ever been diagnosed with gestational diabetes? Meaning, were you diabetic during your pregnancy? If the answer is yes, give yourself 1 point. If the answer is no, just 0 is fine. Fourth question, do you have your mother, father, sister, or brother with diabetes? If the answer is yes, 1 point. Answer is no, 0 points. Have you ever been diagnosed with a high blood pressure? Even if the blood pressure was high for a couple of years and you did a lot of good things and then it went down and all that, that counts too. So if the answer is yes, give yourself 1 point. If the answer is no, it is a 0. And the sixth question, are you physically active? Meaning, can you do some physical activity for about 30 minutes a day for most of the days, which means 5 days? So are you able to walk around and do 30 minutes of activity, brisk activity for 5 days a week? Yes, 0. If the answer is no, 1 point. Finally, weight category. So if you're paying attention to the grid here, see the chart. So say, for example, if you're 5'9", 5'9" height, and your weight range is 209 to 277 pounds range, you give yourself 2 points. So that's how it works. If you're 6-footer and you weigh 294 pounds plus, you give yourself 3 points. So right now, you can do it right now because I'm displaying the grid here. Now, I'm sure you're all ready with your test score. If you scored 5 or more, you're not a diabetic, but if you scored 5 or more, what is the bad news that I have for you today?
Pre-diabetic.
Yes, you are a pre-diabetic, right? There's no controversy, there's no sugarcoating. And I know as a physician, I had to sugarcoat sometimes, but most of the times I deliver the news just the way it should be so that we can take some action on it, right? So if you're 5 or more, you are pre-diabetic. All right, let's move on. So why do we need to care about it this morning on Saturday today? So do I have a question? Okay. So we need to care about pre-diabetes today because it progresses to type 2 diabetes, right? I mean, it's simple. It's just pre-diabetes, meaning if you don't do anything about it, um, it's going to go on to type 2 diabetes, as simple as it is. And we will probably know about complications of type 2 diabetes in a minute so that you will understand the impact of, pre-diabetes. So how do you treat pre-diabetes? Obviously, we talked about risk factors for pre-diabetes. And when you reverse those risk factors, simply that's the treatment. So lifestyle changes, American Diabetes Association recommends lifestyle changes, lifestyle modification as a primary intention. And then obviously, when I say that, the goals are healthy eating plan, moderate intensity exercise, 30 minutes daily, modest weight loss, 5 to 10% of your body weight loss can impact prediabetes. And obviously, stopping smoking will help it. Very rarely, I have given medications to pre-diabetics if they are less than 60 years or younger with a BMI more than 35 or so. When none of the interventions are working, rarely I've given metformin to them for the pre-diabetes, but otherwise there is no medication for pre-diabetes. the medication for prediabetes, the treatment for prediabetes is reversing those risk factors, which are most of the times are reversible, like eating habits and so on and so forth. So moving on to quickly switching our gears and moving on to diabetes here, I'm sure pretty much everybody in the world in the adult section already are aware what diabetes is, and people know it. But I still want to just make a point. We brush our basic understanding of diabetes. So diabetes is two types, right? Simple diabetes is in a condition where body does not make enough insulin or makes no insulin at all, or maybe doesn't respond to the insulin properly. So that's why the blood sugars are high. So insulin plays an important role in the metabolism of blood glucose. So that's why the insulin is not there, or maybe insulin is not being used by the body properly. The metabolism of glucose, the process of the glucose every day is affected. So the sugar is high in the body. Simple. That's what diabetes is. Very important to know about diabetes today, because diabetes is the single most important risk factor for chronic kidney disease. To Pratima's point earlier, chronic kidney disease, apart from genetic conditions, the acquired condition that puts people at risk of having kidney problems, the highest contributor is diabetes. And diabetes also contributes to the heart diseases. And one other important and scary thing, which is not scary, is truth, is that the non-traumatic amputations, meaning that apart from trauma, apart from the injury, losing the leg or limbs, the next frequent condition that can cause the amputations is diabetes, right? Diabetes foot and diabetes ulcers and so on and so forth. So type 1 diabetes, as you all know, young in onset, people who are younger, usually we diagnose that very early during their age. That's the type 1 diabetes, and they have a rapid onset of symptoms. And sometimes, in the younger, maybe in the teenage itself, they present to the ICU with DKA, diabetic ketoacidosis. And, relatively younger child coming in with high blood sugars, 900 and thousands, and acidosis and stuff. It's a straightforward thing. Let's say they're DKA and they're type 1 diabetic. Mostly tend to be non-obese because it is a genetic condition, and then body cannot produce simple insulin in the body. So that's why they present with a deficiency in insulin, and usually managed by insulin injections and with the diet and exercise control and all that. That's type 1. Type 2 diabetes, in contrary, older in onset, no obvious symptoms present in the early stage. They tend to be a little obese or maybe higher on the weight side. Insulin secretion can be there, may be adequate, but the body is not able to use that insulin because of insulin resistance. So they may not need insulin to begin with. They may just need dietary changes, exercise, oral medications, and finally, special circumstances, they may need insulin along with the exercise and diet control. So this is just a very basic kind of brush off our knowledge here about diabetes. So we talked about it briefly earlier, but I still want to say these things. Symptoms of diabetes, as you know, pre-diabetes does not come with any symptoms, but diabetes does come with symptoms. Diabetics can have blurred vision, feeling hungry all the time, feeling thirsty, and frequent urination, losing weight, poor wound healing, are easily getting infected, even from the trivial wounds, and feeling tired all the time and weak and numbness of the extremities and feeling nauseated and vomiting. So, sometimes even, diabetics, not just presenting with these symptoms, when the sugars are high, they are on a trip and they forgot their medication, or they ate a little bit too much of cake, and they just hits them. Their vision is blurred, and then they're like, they're feeling thirsty and all that. So again, these are the most common symptoms of diabetes. Pre-diabetes, most of the times, does not come with any symptoms. Diabetes does. So we talked about what is diabetes and what are the symptoms, and then we probably can talk about complications, because this is a very important slide, and this affects both pre-diabetes and diabetes. This morning, today, we really want to spend our time learning about pre-diabetes and diabetes because of the complications that are waiting if we don't control and take action on the prediabetes and diabetes, right? So if you go top to bottom, strokes, early onset of strokes and multiple strokes could be a complication of diabetes. And go down a little bit. Vision, diabetic retinopathy, meaning diabetes affecting the eye, causing a partial or full blindness may be a complication as well. And early cataracts or premature cataracts, and also glaucoma, where there is an increase in the pressure in the eye. So glaucoma that can probably lead to complications such as partial blindness, full blindness. So these conditions affect the eyes if somebody is a diabetic, poorly controlled diabetics. And then moving downwards, premature heart attacks, angina, coronary artery disease, and congestive heart failures, complications of cardiovascular disease, maybe due to long-standing, poorly controlled diabetes. Moving downward fashion, diabetic nephropathy, meaning diabetic kidney diseases. And then moving downward fashion, and you can talk about diabetic foot, meaning ulcers of the extremities here on the heel or the toes or anywhere because of poor circulation and lack of sensations contributing to the ulcers and the ulcers not healing and contributing to the diabetic foot here. And also, in general, the entire body, which is supplied by the nerves, can go through what is called peripheral neuropathy, meaning that the nerves supplying the extremities, hands and feet, may be affected due to long-standing diabetes, and they can cause these pins and needles, right? They call diabetic neuropathy, pins and needles and numbness. These are the symptoms of neuropathy. That is because of chronic diabetes, long-standing diabetes. And then last but not the least, peripheral artery disease, PAD, wherein people may have occlusion of the blood vessels of the extremities, causing gangrene and causing ulcers and gangrene. That's the condition that leads to amputation, meaning a removal of the part of the limb and stuff because of gangrene, death of the tissue. So I definitely want to spend a minute or two on this slide because I want all of us to understand one important fact here. Fundamentally, diabetes is not a disease of one particular organ. It is a disease of pretty much entire body, right? Every cell that is in the body has to have processes to process the blood glucose. If the glucose processing mechanisms of all the cells is affected because of this, it's a no-brainer. All cells are affected. So in general, this affects the circulation. So that's why when the blood vessels supplying to the eyes and nerves and kidneys and heart and brain are affected because of this general disease of the system, that's why the complications. So how do you treat diabetes? Simple. I mean, like as I said earlier, treatment for diabetes is something that people talked about for decades. We got this. I mean, today, that's why today we're not really gonna spend a lot of time on what are the new medication for diabetes. Is insulin good versus the other? Is CGM good versus the other? We probably may spend a minute or two on that for sure, but we're going to talk about stuff that is not really talked about in your regular PCP offices. So to Pratima's point, I want all of you guys to be empowered with information and knowledge on what you can do at home and also what you can write down and get ready when you go and see your primary care doctors and diabetic specialists. So this is something I came up with. It's a diabetes and prevention. The best approach is multidisciplinary approach, and it is a 3 teams approach. So who is the first team? The first team is always you, right? There is no one else important. There's no one else who is concerned about your health than yourself. So you are the first team. Your first team, when I say you are the first team, you take care of your diet and lifestyle modification because that is proven to reduce the long-term complications of diabetes. And definitely quitting smoking helps. Alcohol abuse and substance abuse has to be also taken care of. And then again, increasing the physical activity. We'll probably get to this part because the majority of our discussion today is going to be on this part. We'll get to that in a second. But again, I want us to know the importance of you being the advocate of your own health, especially when it comes to prediabetes, diabetes. And the next team that is really interested in making you and keeping you healthy is your medical team. So if you're a type 1 diabetic, you have to see endocrinology. the blood glucose specialist, not just the primary care doctor or internal medicine doctor, but your endocrinologist for sure, most of the times. Sometimes nurse specialist under the supervision of endocrinologist, diabetologist can be your point person. You can see them. If you're a type 2 diabetic, yes, you can go to your primary care, keep seeing them regularly, but surely an endocrinologist has to be consulted if the blood sugars are uncontrolled. If you're always running blood sugars in like 200s and 300s, and your HbA1c is like 7s and 8s, nothing is working, definitely request your primary care doctor to refer you to endocrinology, because endocrinologists are the specialists who do this every day. So maybe they have something for you that your primary care doctor may not be able to offer. So I highly encourage you guys to see the endocrinology in case your blood sugar is uncontrolled for a long time. Again, I'm assuming that you've done your part as your own advocate of your health before you go and demand a consultation from endocrinology. Because if you're not doing what you're supposed to do, no doctor can help. So that's one thing. And managing other chronic conditions is very important, like high blood pressure, high cholesterol levels, because as I said earlier, if you have a hypertension, you may have a high risk of diabetes in the future. So that's why control of the high blood pressure, control of cholesterol levels is very important as well. And the third important team is supportive team. When I say supportive team, diabetes educators and education programs, health coaches, medical nutrition therapists, and diabetes prevention programs. If you are a pre-diabetic, you need to be in the diabetes prevention program. If you're a diabetic already, you better see the diabetes educators or nutritionists at least once a year, and then see if there are any programs that are important and that may be able to help you. So that's why this three-team approach is very important for a pre-diabetic or diabetic. And I can't emphasize anything, particular this thing enough, how important it is. So talk about diabetes, right? And when we talk about diabetes, the next thing that comes to everybody's mind is, oh, what can I eat? Diet. I mean, again, I just put it intentionally. You shouldn't be eating all of this, right? So let's just move into a very tricky question for you. Which of the following is a superior diet for pre-diabetes or diabetes? Keto diet, low-fat diet, paleo diet, vegetarian, vegan diet?
Vegan diet or vegetarian diet?
Good thinking. All right. Okay. So
Is it low-fat diet? No.
So all are good answers. All are good answers, but typically there is no one particular magic diet for the diabetes. Everybody's body responds different to different types of foods and diets. So there's no one particular single magic diet for diabetes or pre-diabetes. We'll talk about it. The reason why I said there's no one particular diet that is standard for diabetes is because if you're doing one thing all the time, you're missing out on many other things. Some people ask me, "Hey doc, I've been on just protein diet. I'm not eating any fat at all. I'm not eating any carbohydrate at all. Oh, I'm gonna lose weight." And I simply told him, I mean, he's my very close friend. He's, you're gonna lose weight and you're gonna lose mind too. You need to have sugar, blood sugars. You need to have carbohydrates. You need to have, fats, and they're all essential nutrients in the diet that you need to have. So, yeah, you can lose weight, but don't lose your mind, because you need a balance of that. We'll talk about it in a second. So American Diabetes Association recommends eating a particular eating pattern. Again, as we said, there's no one particular diet. So ADA recommends eating non-starchy vegetables, minimizing added sugars and refined grains, choosing whole foods over processed foods. We'll get into this real quick. So it's a 9-inch plate. It's not like a big, massive plate that we all have at home. No, it's a 9-inch plate. When I say plate method, the size is, okay, there is a standard. You just cannot go anything more than the 9 inches plate. So simple, you fill half of your plate with non-starchy vegetables. Half of that has to be with non-starchy vegetables. 1/4 has to be lean protein foods. We'll talk about it, what they are in a second. And then other quarter has to be grains and starches, and always supplement your plate with water or 0-calorie drink. It's not a substitute, it's a supplement, right? So question, which of the following is a starchy vegetable? There's a giveaway, right? So sweet potato. Now, okay, hold on to this slide for a minute or so. This is exactly the stuff that you need to fill half of your plate. Okay, so these are non-starchy vegetables. They have to be filling half of your plate. And typical example in our cultural style of eating, yeah, we definitely do a lot of carrots, celeries, eggplants, mushrooms, peppers, um, cauliflower. Yeah, I've seen a lot of that at my home for sure. And yeah, sure, you do have a choice of things that you can actually fill half of your plate, right? You do that every time you eat, right? So try to eat at least 3 to 5 servings of vegetables a day, and that should really fill your half of the plate twice a meal that when you're doing. So hold
Quick,
on to that thought there.
quick question,
Yes,
Chandra. So, should these be cooked or non-cooked, or
cooked
anything
is
is
fine.
fine?
Anything is
Cooked
fine.
is
Yeah, anything is fine. You can cook them. Typically, with the typical cooking conditions that we do, we don't really lose a lot of vitamins and nutrients from this. Yeah, cooking is fine.
great. Okay, thank you.
And protein. So we talked about the quarter of your plate has to be protein, and then we talked about lean protein. So lean meats, fish and seafood, poultry, chicken and turkey, cheese and eggs. And for people who do not eat any animal-based protein, of course, we have a lot of choice, right? Beans, lentils, peas, and nuts, and tempeh, tofu. We have a lot of choice. So compared to individuals who consume animal-based protein, plant-based protein consumers have a lot of choices. They can actually make it a very interesting every day. So fill a quarter of your plate with these materials. And then we talked about plant-based proteins. Again, go into the little details of this. These are the 7 high protein pulses that have a lot of protein: black lentils, chickpeas, and kidney beans, navy beans, black beans, split peas, and green lentils. So this is something that is there in everybody's home. If not, you know where these things are available for sure. So that's why very important to pay attention. And again, the numbers written here are how many of these hazelnuts make a portion. So more carbs are on this side, cashews and pistachios and stuff, and fewer carbs on pecans and Brazil nuts and macadamia and walnuts and almonds and peanuts. So these are also plant-based protein sources. So again, some of them have essential polyunsaturated fatty acids, very important to your brain and heart health. So definitely include these part of your protein diet every day, right? So moving on to greens and starches. So we talked about half of the plate filled with non-starchy vegetables, the other half shared by lean protein and carbohydrate. We talked about the diet, right? So I was joking earlier that if somebody is just on protein diet every day, all day, forever, I was joking that they may lose their mind because you need carbohydrates to run the factory every day. You need to run around, you need to do things, you need to exercise, you need to have a immediate source of energy. So that's why you need to have uh, carbohydrates which are rich in immediately available glucose. So but what you want to choose, you want to choose grains, starchy vegetables, beans and legumes, fruit and yogurt, and then also food that have the greatest effect on the blood sugar for that portion. So the caveat is that you choose the whole grains: brown rice, oats, quinoa, whole grain products like bread, pasta, tortillas, and starchy vegetables like acorn squash, butternut squash, and green peas and parsnips, and whatever that is listed here. So definitely, and also fruits as well, fruits and dried fruit, and dairy products like milk, yogurt, and milk substitutes. They have a carbohydrate. So which are the following fruits to be avoided? I listed here banana, orange, mango, peaches. Which one you should avoid? Quickly, in 1 second.
Mango.
Mango. Yeah.
Okay. All right then. Okay. No, none.
Okay.
Right. So do
Banana,
not, no,
banana.
no, do not skip any fruit. Just to make it a part of the meal plate, you can eat half cup or small portion of the whole fruit, and you factor that into your carbohydrate portion. Say, for example, if you're really craving for a mango, you just Google it. You just find out, okay, one whole mango, how many calories would it be? If it says 200, yeah, your 200 calories of your daily allowance for carbohydrates is done, gone. Don't eat any carbs anymore. or if you eat about 600 calories of carbohydrates every day as part of your meal plan, you eat one mango, 200 taken away, you have 400 of carbohydrates. So that's why make it a part of your meal plan, but do not skip any fruit, because fruits are very important source of multiple nutrients, micronutrients like your minerals and vitamins and so on and so forth. That's why do not skip any fruit. So there are some fruits which are more friendly, meaning look for these low glycemic fruits, meaning that these are the fruits that do not give instant kick of glucose. And these are cherries and grapefruit, dried apricots, pears, apples, oranges, plums, and berries. So you can choose these to the other. So yes, your answers are spot on. They may have a lot of glucose, but again, don't skip them. If you want to eat fruit, maybe choose one of these. And if you don't have any of these available, you can choose the other ones. But just make sure you know how many calories in the fruit that you're about to eat, and can you minus those calories from your total daily intake. So that's I just wanted to convey that to you guys. Healthy fats, we talked about it. You really need to make sure you factor in the healthy fats in your diet. Sources of polyunsaturated fatty acids and omega 3s and 6s. Important items to to note: walnuts, good for heart and brain. Eggs and canola oil, flax seeds, and tofu. A lot of these items have fats that are very important for you, for the immunity, and also for the heart and brain health as well. So definitely don't skip them. We talked about it a lot, and I know you already know the answer. Low calorie drinks. Best drink is what? Yeah, I got the answer, right?
Water.
Yes, absolutely. And then if you must, you can probably do some unsweetened tea, coffee, or anything, but don't add any sugar. That's the whole point of supplementing that water or 0-calorie drink to your plate, because you're not adding any sugar. If you're adding any sugar, you're gonna just think about carbohydrate intake. So this is what we talked this is what we talked so far. Again, the summary of those slides: fill one quarter with the whole grain starchy vegetables, and then other quarter with lean protein. The entire half of the 9-inch plate, again 9-inch plate, go home and check what 9-inch plate looks like, and fill the entire half with non-starchy vegetables. Supplement with skim milk or 1% milk. Again, think about these calories, or maybe water, 0-calorie drink. And then again, eat a small portion of fresh fruit, and think about how many calories it is, and can you take it from your daily carbohydrate allowance. And that's it. You should be happy. I think I saw a question from the audience.
I just have a question, Chandra. So this is all good, and it's kind of surprising to many people that the food that you have shown there, it's kind of defeating everyone's thought that something is good and not good, but it's kind of an equal balance will always help for everyone. And what if somebody has some allergy to certain food items? So, for example, apples would be the one, or peanuts. So, for them, what's the best way to substitute such food with any other?
Yeah, good question. Great question. So again, as I said, that's the beauty of working with the I think I put the third team as a supporting team. The supporting team has dietitians, nutrition therapists, so they do have access to tons of choices. They do have access to education, so we can probably get ourselves self-educated. So if you say, for example, if one particular person is allergic to one particular nut or one particular substance, the substitutes and alternatives are there. You can consume them, because like I said, I always thought, long time ago, I always thought vegetables are vegetables. What's the big deal? But there are starchy vegetables and non-starchy. So in that fashion, the substitutes in that category that they're not allergic to are available, and they can simply switch them. Hope that answers your question.
Thank
And
you.
I think you're welcome. I think Madhurima, Madhumita Guha.
Yeah. So, doctor, I have a question on using sugar substitute, for example, for non-sugar tea or coffee, so Splenda or other substitutes. So what's your thoughts here? Like, because we have heard negative press on using Splenda, stevia, etc.
So as far as my experience goes, yeah, non-sugar substitutes are they're welcome. They whatever the risk associated with those, obviously subject to the judgment or decision by individual consumers. But as such, um, the the plant-based sugar substitutes um, uh, seem to have no problem. So my short answer to that is that they really are zero calorie, because that's how they are chemically structured. They're zero calorie, and the choice of them, again, based on the individual. Some individuals have allergy, not allergy, intolerance to some of those. Some of the substances give headache. Some of them substances give some other symptoms. So again, it's subject to the individual consumers choice of which one they want to go for, because that is something not scientifically studied, right? So that's why I don't think I'm in a capacity to evaluate them either way. But they're zero calorie by the way they are structured, and then again, it is up to the individual to see if there is something that worked for them. Sure, they can go for it. They're zero calorie. Apart from that, I don't think there's any other scientific evidence available to evaluate them. One is better than the other versus the other, but they're all zero calories, and they do a good job in substituting for the sugar.
Thank you. And I have one more question. So in a 9-inch plate, what you're mentioning, doctor, it has to be like, our daily, so our breakfast, our lunch and dinner, each should be 9-inch plate.
Yeah, yes, absolutely. So that is okay. So what's your total daily calorie estimate, or total daily calorie allowance? So that's exactly is going to drive how many of those 9 inches plates, how many times, and 9 inch plate for the breakfast, or all those things. So when I say that, what I mean is that if we are somebody who's working 8 hours a day, 9 hours a day, building things and moving things around, walking, I don't know, several miles a day as a part of work, we probably need 1,800 to 2,000 calorie diet. If somebody is sedentary, just sticking to the computer all day, not really doing a lot and stuff, they may not need 1,800, 2,000 calorie. They may just need 1,200, 300 calorie. So that's why this notion of in diabetics, 1,300 calorie diet, 1,500 calorie diet, this kind of caloric intake, things came into picture, factoring how much of activity. Again, how much you need to eat. The simple thing is, can you spend all of it? Because you don't need to reserve. We have food available every day. So you need to eat as much that will get you through the day. Meaning, if you are somebody who spends about 1,200 to 1,400 calorie, your 3 plates in a day have to be total those 1,400 calorie-ish. Does it make sense? Let's take a look at this daisy plate method, courtesy of my friend who sent me this and asked me to play, because you may have
Doctor, you may want to reshare that with the sound on.
Were you guys able to see it?
Yes, we are able to.
Wonderful. Okay, so simple, right? So, so far we talked about the dietary kind of education, and talked about the dietary choices based on whatever that is available in the places where you live. But if I had to reflect on our cultural habits here, you see half of the plate is filled with non-starchy vegetables, a mix of those, right? There are a lot of them available. And then 1/4, rice with other things, and that's fine. And then another quarter with, something proteinaceous too. So look at that. So I think this is very powerful. And moving on to the next video, pay attention to this. All right. So key takeaways from the diet, as per American Diabetes Association, there is no single diabetes diet. You got to talk to your doctor to get a referral to a registered dietitian or diet nutritionist to help you figure out what eating plan makes most sense to you and your treatment goals. And again, as I said earlier to one of the questions one of our friends asked here, whatever the diet plan you choose, be sure to include lots of non-starchy vegetables, minimize added sugars, refined grains, and choose the whole minimally processed foods. And when I talked about refined grains, polished rice, white rice is just a pure carbohydrate, whereas the brown rice or rice with some brown and stuff like that would be a rich source of vitamin B12 and other important macronutrients, right? So that's why the more refined they are, the less nutritional value they have. Of course, they have a lot of calories, but they don't have a lot of nutritional value. So that's why I'm a proponent of whole grain, less refined foods. More processed food, more bad news, right? And then again, macronutrients. We talked about it. Again, to your question, Madhumi, I think somebody else asked the question about choices and alternatives if they're allergic to one. If somebody is allergic to one, obviously they have to choose an alternative. And in each category, there are lots of choices available for sure. And then again, as the reason I said very important to check with the check with the nutritionist or a specialist, or maybe just you can have your own individual plan. There are lots of applications and lots of knowledge out there available for you to do self-driven um, you know self-driven nutritional plan for you. We talked about physical activity. So again, to put the numbers into perspective here, 30 to 60 minutes a day of moderate intensity aerobic activity for most of the days a week. So a minimum of 150 minutes a week, meaning if you can work out 30 minutes a day for 5 days a week, that's good enough. That's the minimum. That's the least. You can go more than that, but when you're doing more, make sure. If you're a pre-diabetic or diabetic, you make sure how many minutes of exercise that you're doing, how many calories you're burning. You take that into consideration, because I don't want you guys to go hypoglycemic. I don't want you guys to just pass out because of hypoglycemia and sustain injuries and stuff like that. So you just need to make sure you do that. We talked about weight loss earlier. Again, I cannot stress the importance enough. Um, you know, 5% weight loss, 5 to 10% weight loss. So 5% weight loss is enough to drive somebody back to normal from a pre-diabetic status. If somebody is diabetic, even a 5% weight loss can help them to get rid of the insulin, or maybe help them to reduce the number of oral medication they take, or maybe that will put them back into non-diabetic status. So I've seen people who walk back into normal, after they did all those things important in their life, so they don't have to take insulin or medication. So very important that weight loss is given a priority here. So before, we can take some questions, but I really want you guys to focus on this slide for a minute. So very important diabetes management checklist. This is something you really want to pay attention to. Balanced meal. We talked about it. The reason why I talked a lot about balanced meal, what exactly that explicitly means today, is that it is important that you do it every day. Exercise 30 to 60 minutes a day, at least 5 days a week. Medication compliance, very important. Medications are important to control the blood sugar. Again, as I said, it's not it's not just elevation of blood sugar once or twice that is that's, of course, that will damage the body, but long term poorly controlled diabetes will affect the body. That's why we really need to make sure you take the medication and reduce the number of days of high blood sugar. So that's why you gotta be just on the clock and taking your medication important. And especially when you're traveling, again, some tips here. Obviously, you all are pros in that. You already know, making sure you take enough medications and supply when you're going on a vacation. Put them in the handbag already, always, and don't put them in the check-in luggage, because you never know, this check-in bag sometimes can be lost. So that's why you just put your medications in your handbag all the time, and then get a list of all the medications, printed and put in your wallet and wherever that you are. This is one thing. When people come and show up to the appointments and go to their doctors and say, "Do you have your medication list?" "I don't have it." "Can you drive without a driver's license? Can you go anywhere without your wallet, without your debit card, credit card?" No. When you think it is very important to have your driver's license every time you drive, come on, this is our life here, right? So medication list has to be in your wallet all the time, on the phone or a wallet. I don't care where it is, but you need to have it, because what happens, if somebody passes out and I'm looking at, oh, he's a diabetic. I mean, let me just get him to the urgent care or somewhere close by and just let them give a dextrose, whatever it is. So people who are walking by will know that you're a diabetic looking at your medication list. And again, testing and recording the blood glucose regularly is very important, because as a physician, I need to know how your blood sugar have been, and you also need to know how you're doing. Very important. And keeping appointments with the healthcare providers is very important. Healthcare providers are there asking you to come and see them frequently for a good reason. If you're a type 1 diabetic, you should be seeing your doctor every 3 to 4 months if possible, maybe less than that. But if you're a type 2 diabetic, every 6 months you see your primary care doctor. You get your HbA1c test done at least twice a year. You can do every 3 months. One important mention about HbA1c test: it tells me how your blood sugars have been in the last 3 months. Very important. So if you come up today with a fasting blood glucose of 88, because you really behaved very well, you didn't eat the cake yesterday, you behaved so well to show me that, oh, I've been a very good diabetic doc, and today my sugar is 90. I'm like, good for you. But it doesn't tell me how you've been doing for the last 3 months. HbA1c tells me. The HbA1c, if it is like 7.5 or 8 or something, it tells me that your sugar has been consistently high in the 180s and 200 range consistently. Opposite to HbA1c of 6.7 or something, it tells me that, oh, you've been really well for the last 3 months. So HbA1c every 3 months is recommended, but at least twice a year, very important. And eye exam once a year, we talked about it enough today that it is important that you see your eye doctor if you're a diabetic once a year, so that they can do the retinal exam. They can just do a comprehensive eye exam to make sure the early signs of eye disease are caught, in other words, early, so that the doctors can have some time to respond and then treat that. Dental exam: diabetes affects the gums and teeth differently compared to non-diabetics. So every 6 months, dental exam is highly, highly recommended, because what happens if there is something that is happening in the tooth or gum, and then they don't detect it, and they don't go and see the dental doctor, that develops into an abscess, and that abscess will immediately trigger the high blood glucose episodes. I have seen people who end up in ICUs on the diabetic coma because of hidden tooth abscess for several months, because they didn't see the dental doctor to pick it up on time. Very important to see the dental. And again, when you're especially sick, checking blood sugars regularly and making sure you pay attention to your blood sugars is very important. Good foot and skin care, we talked about it, because thing is, we think that, okay, I don't have any problem with my feet, so I don't need to see my podiatrist. As a diabetic, all diabetics are entitled to get a foot exam done every year. Every insurance has to cover Medicare Advantage. Every insurance has to cover the foot exam, preventative exams every year. So see the foot doctor, even if you don't have any foot problem per se. Ask for referral to podiatrist, foot doctor, so that the foot doctor can take a look at it and say, hey, you have an ingrowing toenail. You have something wrong with your bunion, or something wrong with your great toe, ball of the great toe. This is something that you need to work on. You probably need to change your shoes. I see some early signs of ulcer. Remember this: if there is an ulcer or something to the foot, your doctor may give you antibiotic and wound care and all that. Why doesn't it heal in diabetics? Remember, in diabetics, poorly controlled diabetics, there may be something wrong with the circulation, right? So whatever the antibiotics I'm giving may not reach the tip of the toe because circulation generally is bad. That's why that ulcer is not healing. When the ulcer is not healing, my antibiotics are not reaching. There's not enough healthy tissue to grow, even though the wound care is scraping it and working on it. Nothing is helping. The ulcer is going to go deep into the bone and cause what is called osteomyelitis or maybe gangrene, death of the tissue and the bone, death of the bone and infection in the bone. And I don't really have any choice other than recommending removal of the toe, removal of the half of the foot. That's why people end up in amputation because of poorly controlled diabetes and not paying attention to the feet. So important to see your foot doctor once a year, maybe more frequently if they recommend. And managing stress is important because stress will contribute to high levels of adrenaline in the body and high sugars and uncontrolled sugars. And absolutely no smoking, because thing is, smoking is associated with high risk of diabetes, pre-diabetes, and complications, and acceleration of other disorders. That's why absolutely, you got to quit smoking. For pre-diabetics, there is a program called National Diabetes Prevention Program. It is available at multiple places. I'm working with Pratima Garu to come up with a list of DPP programs available in the area. So, again, tap into VFS resources to see if you can find your nearby DPP program. This diabetes prevention program will help the pre-diabetics to get back to normal, because thing is, if they are in this program, there's a 58% chances of reversing their type 2 diabetes risk. That's a lot of percentage, right? If somebody is a pre-diabetic, they engage in the diabetes prevention program, 60% of the times, or maybe 60% of them will not go and become type 2 diabetic. That's a good. I'll tell you the real life example. Several of my friends gotten, or people that I know and my family members and stuff, gotten into this program, DPP program, because they're pre-diabetics. Their serum creatinine, meaning they already have some kidney problem because of pre-diabetes and all that. They not only lost weight and reversed their pre-diabetes, and even their kidney problems also reversed too. So if you're a pre-diabetic, don't just say that, oh, I was told I'm a borderline diabetes, I'm okay. No. Oh, my doctor said he's watching me. Watching you what? Watching you become a diabetic? No. You have to respond to it. I just cannot tell you enough the importance of responding to diabetes, pre-diabetes. If you're a pre-diabetic, think about reversing it, period. No compromise, right? So important. And these are the references that are available in the deck I'm going to send you guys. I'm going to send the PDF of this deck that is available to you. And that's all I have for you in terms of talking to you, but I'm here definitely to take all the questions.
Thank you so much, Dr. Chandra. I have a couple of questions which I know even others may have to ask you. I would love to ask you. This is with respect to our pre-diabetes. So what, according to you, are the signs of being, which is already explained about the signs of being pre-diabetic, but how long does it take to go from pre-diabetes to normal? Even though you explained that part.
Yeah.
Just wanted to clarify that.
It is, so these diabetes prevention programs are very intense programs that focus on the lifestyle, focus on exercise, focus on the diet that you need to take. Most of the times, no medications, right? So typically, it takes about 1 year to have a meaningful. Well, they see the changes as soon as they start, maybe in a month or two, but to tap into the full beneficial effect of lifestyle modification and dietary changes and all those things, and then reverse the pre-diabetes, it takes a full 1 year. That's why these DPP programs typically, whether they're administered by a local hospital or outreach department or anybody else, they're designed to run for 1 year, where they see these individuals every week for the first month, then every 2 weeks for the next 2 months, and then every 2 months or so. And then where every week they're coming and saying, okay, so Chandra, you have tell me about what you've eaten. What is your calorie roster for the last 1 week? Okay, how many hours you exercise? How many hours you meditated? Like the lifestyle changes. So short answer to your question is 1 year. But will they see the effect? Yeah, sure. Within a month or two, they'll see the effect. So the burden of all this pre-diabetes thing that we mounted for several years, Yeah, sure. We gave our body to misbehave for so long. Let's give it at least 1 year to go back to normal, or go back to better being better with all this. So hope that answers your question.
Also
I'd
have
like to ask,
yeah, please carry on. I can ask later on. Yeah, please go ahead.
I wanted to ask if these links you gave us are, where can we go to actually work with a person, not just read charts or something? Hospitals or,
Yeah, so hospitals have hospital outreach programs, hospital diabetes programs, hospital diabetes departments have these resources for diabetics, medical nutrition therapists, diabetes educators. They call DSMES, diabetes self-education services. Diabetes coaches are available for pre-diabetics. Lifestyle coaches and nutritional thing, they all tucked under one program called Diabetes Prevention Program, DPP. Your local hospitals may have a program that they already run. There are independent third-party people also run the DPP programs. Most of the times they're in person. Sometimes they could be hybrid. Yes, the resources I am sharing today may have some info, but I definitely am working on a list of your local available DPP programs in Massachusetts, and I'll send that list to VFS friends here, and that will be available on their website or however they want to distribute. But I'm happy to work on that because that's my homework for this weekend.
thank you. I got an appointment with a nutritionist at my hospital, but it's 6 months to get an appointment.
Goodness. Yeah, that's typically. I'm glad they're busy because there are so many people. They're helping so many people. That's good. But at least you're right. I mean, you have a lot of choice. Hybrid versus partially hybrid versus full in person. Most of these programs are effective when they do in person. And again, as I said, there's only so much the medications can do. And before medications do their own thing, we got to make it, we got to prepare our body so the medications can work, and sometimes we may not need any medications.
Thank you.
Dr. Chandra, I was talking about this when I was listening to the obesity part, which you said, right? So this obesity is, of course, a disease. It's something created, of course, by lack of maybe hormonal disease too. And there are many hormones involved. And one of the main ones is definitely what you explained about is a hormone, which is insulin. So what does that exactly mean? If, when people talk about to be resistant to insulin, generally for explanation.
Yeah, so the insulin resistance is, insulin is hormone, discretely a hormone with a very specific task. Insulin helps the cells to process the glucose. So the insulin resistance can be caused by multiple conditions. One of them is, obesity and having a excessive amount of fat tissue in there, increasing insulin resistance, and then there are many other conditions too. So to answer your question, the causes of obesity may be different. So you treat the root cause, and then reverse the obesity. In turn, the reversal of the obesity or taking care of obesity will help the body to reduce the insulin resistance. So insulin is available to the cells, and cells can process the glucose. That's one aspect of it. So as such, insulin may not cause obesity directly, but the other way is true, meaning obesity can contribute to the insulin resistance in the body in general. So when obesity or excessive fat in the body is taken care of, automatically that will help the insulin resistance. It will reduce insulin resistance so that the whatever that we're doing will be more effective. So it's a topic all by itself, but definitely it's important. It's important that we understand the relationship between those two.
Dr. Madhumita has some question. Madhumita, go ahead.
Yeah, so Dr. Chandra, you're mentioning about DPP programs. So is DPP programs covered by most of the insurance?
DPP programs are very good question. Most of the DPP programs are rolled out by the hospital outreaches for free. As far as the if some DP programs are, charging something, it's definitely a good idea to have a conversation with the insurance, because there is, it may be dependent on what kind of insurance you have. Of course, insurance companies and your diabetic clinics or whatever the healthcare outfit that you're affiliated with are interested in keeping you healthy. So to answer your question really, straight, DP programs usually are at no cost, but if there's a cost, again, that's worth the conversation with the payer. But as such, there is no one blanket rule that says, because most of the insurance companies cover, certain number of nutrition visits per year for diabetics. For the pre-diabetics, there is no concrete rule that exists, but it's definitely worth having a conversation, because insurance company outreaches and insurance company case management departments do have access to that.
Dr. Chandra, there's a question from one of the seniors who had actually emailed me. Do I need to take medication, or can I try lowering my risk through lifestyle changes? This is for the pre-diabetes.
Okay. For the pre-diabetes, the first approach is modification of lifestyle. Yes, lifestyle change is the first intervention, the best intervention, meaning, again, same thing, exercise, diet, and other things that we talked about today before we get to medications. Very rarely people may need medications.
True. Yeah. Yes, anyone else can please go ahead with your questions.
Me, Rafa. So I'm 80 years old. How many minutes I have to walk?
About 30 minutes a day for 5 days a week. Pick your pace. If you can walk reasonably, quicker, like apart from the routine, regular, walking style at home, a little bit brisk walk will be better. If you are, just making sure you're safe and your, joints and body and the environment, everything cooperates with. Say, for example, if you're able to do a little brisker walk, 30 minutes a day is okay. But the walk has to be a little slow, considering everything we just mentioned. You could probably do 40 minutes, 50 minutes of total walking a day to be considered as a sort of moderate intensity exercise. Yeah.
Thank you.
You're welcome.
Radhagar, actually, this is amazing that Radhagar is 80 years old. You don't look like that. Hats off to you, because you do a lot of exercise. Yeah. I have this question for seniors, Dr. Chandra. Can they reverse diabetes in old age? Because, sometimes it is entirely possible to reverse type 2 diabetes, right, in seniors?
Yeah.
Very good question.
Possible to reverse pre-diabetes. Is it possible to reverse diabetes in the mature population? It really depends. It's really individual based. What stage of diabetes are they? Are they on insulin? If they're on insulin, what kind of insulin is it? So there's different levels of advanced disease, right? Somebody could be on high levels of insulin with all the supporting activities, such as everything else. We can probably reduce the total need of insulin and then fall back to oral medications and so on and so forth. So there is a way we can probably think about reducing the dependency of the seniors on the insulin and other medications, when we take care of everything else. And then when it comes to removing somebody totally from all the medications and everything, because now they're non-diabetic, again, it's individual based. There are instances where people could graduate from insulin and medications, fall back to the lifestyle and pre-diabetic or maybe normal. But it really depends on the person to person, but it is not impossible. Because there are other things to somebody else's point here, there are other things that we need to keep in our mind in terms of the comorbidity associated with it. Like even if somebody really badly wants to lose weight, they just simply cannot, because there are many things associated with it. Even if somebody badly wants to do exercise, the arthritis and those kind of things may not be cooperating. So in those kind of scenarios, weight reduction surgeries and stuff. So whatever that intervention that can be done to really kind of help with the other risk factors and other contributing factors is helpful as well. So thinking about reversal of the disease and also thinking about reducing the dependency on the medications, the doses of medications, the number of medications, and those things too, is a good quality of life too. So again, to your point, working on many other things that are not just medications, the other supporting and contributing factors will help them to have a great lifestyle. So a little bit of less insulin is definitely good news. If no insulin at all is a great news, just medications and lifestyle and diet and so on and so forth.
So is this the same answer you would love to give it, even when someone talks about what's the most effective management of type 2 type diabetes in the elderly, specifically for them? It should be same thing, right? It should be more of their lifestyle changes.
Yes, lifestyle changes. Diet, definitely. Diet, activity, taking care of everything as a whole, have a lot to do with improvement in type 2 diabetes. Yeah. So pre-diabetes, diabetes, same strategy, except medications. The other strategy is the same.
And Dr. Chandra, when you remember when we were just talking about the outlook for people with pre-diabetes, right? So that outlook definitely, if it increases once the risk for the pre-diabetes increases the risk for having heart disease, stroke, and having diabetes, right? But they can always take steps to lower that risk. And that's what you were explaining about the risk part of it.
That's why recognizing pre-diabetes and reversing it will tremendously reduce the risk of multiple organ complications, because that is reducing the risk of becoming diabetic. Becoming diabetic and being diabetic may put them at high risk. Again, not necessarily. Poorly controlled, uncontrolled diabetes is the reason why people go into complications. Pre-diabetics will need to respond to it and take care of it so that they'll never become diabetic. So then the risk is already low. So that's why recognizing that they have pre-diabetes and responding to it and reacting to it and then reversing it. That is not triple R, 4R. You recognize it, you respond to that and you react and you reverse. You can do that. I think so that's the best strategy, is to prevent before something really hits us.
Mary has a question.
Yeah, sure.
Yes, I wanted to ask, what is a good calorie count for a senior woman each day?
Yeah, good question. So again, how much of activity you do every day, like how many steps you walk, what are the activities, and how many calories you'll be spending doing all those activities is what is going to drive how much you can eat. If that activity only makes you spend about 1,200, you should be eating about 1,200 plus or minus. Shouldn't be eating 2,000 calorie diet if you're only spending half of it, because the other half is going to be stored right in the belly somewhere. So yeah, how much can you spend every day is going to drive how much you can eat.
Is it like what I've read? It's like 1,200 calories a day for women, and then you adjust it. Is that right?
Close to, yes, that's right.
Okay.
That's typically how much we spend. Yes. Okay, so that's how much we take.
Okay.
Dr. Chandra, on the same question, does it relate to the body type of any individual to the number of calories required?
No, it's activity. It's purely on the activity.
So the standard 1,200 applies to any person.
I wouldn't say so. If you assume that they do what a typical adult does, like not being in the couch all day and not just kind of thing. So that's why a typical activity for an adult in a day should make them spend about 1,200, 1,300. So that's why these typical number standards came up, because assuming that the adult does the standard amount of activity with their daily living. So that's the number. So I wouldn't say that's the standard for everyone, because someone who just sitting all day watching TV and just do nothing and wouldn't be spending more than a couple of hundred calories. So 1,200 already is high for them, right? So that's why a standard adult, assuming that they are spending all those calories, by doing the activities a standard typical adult is expected to do, like walking 5,000-6,000 steps a day and doing this activity and pushing and pulling and cooking and walking around and bathing and those. So that's why.
So if I say spend all the calories that you eat on the same day by doing whatever. So if a person eats 1,200 calories, I believe on the lighter side, even sleeps make burn some calories so they can sleep for 4 days.
Yeah, you can
These are
can
confused people, Ramu.
yeah no again yeah, you invest, you do that every day, so the repetitive actions every day count, and not the cumulative. Yeah, cumulative bad habits will count, but
Mhm.
repetitive good habits every day count. So
Yeah.
the reverse is not true.
Actually, on this, I wanted to tell to all the family caregivers that, caregivers are very important, right, for helping people manage their diabetes. And I think the best way is what Dr. Chandra was explaining now is to, on our part, we can prepare healthy meals, make and shop for foods that don't cause the person's blood sugar to surge. One is, as Dr. Chandra was explaining, about encouraging exercise, that invite your loved ones with diabetes to get moving with you. Such as, of course, on walks. So hats off to Mary and Radha Garu, and with other physical activities. And I think we all need to remember and remind ourselves that one has to help the person, or help the person remember when to take medications, and remind him or her to do the blood sugar checks on proper schedule. Which is, I know that most of people, sometimes you forget it. And also to keep watch on the outlook, what do you call that? Lookout, sorry, for symptoms of diabetes related complications. And as Dr. Chandra was constantly repeating, that you have to do the checkups, making sure that accompany your loved ones on a regular doctor visits. I think from today's talk, the little takeaway I got, and I'm pretty sure everyone must have got today, is that if you have the risk factors for pre-diabetes, you need to talk to your healthcare providers, about getting your blood sugar checked regularly, because these pre-diabetes checks are very essential, because they often have no symptoms, but you can have it. And pre-diabetes, it's it puts all of us and whoever has it at risk, increased risk of developing type 2 diabetes, heart disease, and stroke, and many more. So again, I would finally want to conclude here by saying, the diabetes is a serious, life-threatening disease, must be constantly monitored and effectively it's subdued with proper medication, and by adapting to healthy lifestyle, which Dr. Chandra was constantly asserting on that. And by following a healthy lifestyle, regular checkups, proper medication, we can all observe a healthy and long life. Dr. Chandra, thank you so much for today's, and I think I just wanted this little bit gone over time aboard, but I'm very much happy that I hope so everyone learned a lot today. And we will be having all the resources what Dr. Chandra has spoken today. We'll be putting it on our website under our resources. Thanks again for everyone. And thanks again, Dr. Chandra, for being here and spending your valuable time with us.
My pleasure. Good day, guys. Thank you.
Thank you.